On something we see very commonly. I would now like to invite our next speaker, Dr. Nicholas Vijay Rao, who is an assistant professor in gastroenterology, CMC Vellore. He's published research on the impact of COVID-19 on caustic ingestion and malnutrition in rural elderly populations, and is also conducting ongoing research on early readmission rates in patients with acute pancreatitis. His areas of interest are IBD and pancreatitis, and he will be discussing newer molecules for treating IBD, focusing on advanced treatment options too.
Good afternoon. Initially, I was thinking gastro has been given the post-lunch session and everybody must be sleeping. But then strategically must have been placed because the talk was on constipation. And the most best time for bowel motility is half an hour after food intake. So with that, I'd like to talk about something totally different. The newer molecules in IBD treatment. So the outline of my talk is epidemiology, introduction, the integrin inhibitors like vedolizumab, IL-12, 23 inhibitors, ustekinumab, P19 inhibitors like risankizumab and some other zumabs, JAK inhibitors, which I'll be talking a little bit more because that is what we commonly use in CMC, tofacitinib and upadacitinib, and the sphingosine 1-phosphate modulators such as ozanimod. So looking at the epidemiology of IBD, initially, it was more in the West, but over the last few decades, if you look at sorry, can I have a pointer? So the incidence of IBD is actually coming down in the higher socio-demographic index populations, whereas it is going up in places like India. So over the last 1990 to 2019, the IBD rates have almost doubled in patients in the Indian population. A brief pathophysiology and the targets that we see. So in IBD, we all know that there is gut dysbiosis. Okay, and there is also a problem with the tight intercellular junctions, and also there is leaky gut, along which the bacteria enters the gut, and then the activated macrophages produce your interferons and your interleukins, and also they get home to the lymph nodes, and from where you can get the T cells, T cell subsets going to the areas of inflammation. So these are all targets which we can use in IBD, the newer targets. Look at the timeline of drugs which have been used in IBD. So we all are aware of the steroids and azuran and sulfasalazine and the 5-ASA compounds. But going on from the TNF era, we go on to the anti-integrins in 2013-14, and then the IL-12, 23, ustekinumab. And then till recently, we have a newer JAK inhibitors such as tofacitinib and P19 inhibitors such as risankizumab. What is the problem with TNF blockers? TNF blockers, the problem is initially around 30% itself have some primary non-response. And by the end of first year, around 20% lose response, secondary loss of response, and almost 13% annual loss of response from there on because of the production of anti-drug antibodies. So what has changed recently in the treatment of IBD is something called as treat to target, where apart from just looking at clinical response and clinical remission rates, we set predefined or pre-specified times where we have to check patients' biochemical response in terms of fecal calpro and CRP levels. And also at the end of 1 year, or usually at the end of 6 months or 1 year, we also do an endoscopy to look for endoscopic healing. Apart from that, especially for Crohn's, to look for transmural healing, we can even do imaging. So these we set at predefined, pre-specified targets like 3 months, 6 months, 1 year. And then we target our therapy not just based on clinical response, because the patient may actually say he's okay, depending upon all the clinical indices, but he may be having active inflammation in the gut, which will be only picked up on endoscopy or imaging. The problem with IBD is that this early, we diagnose them here, and then they have a flare and remission. But this is the window of opportunity where if we treat them properly and aggressively with focused therapy, then we may prevent them going on to surgery later. This I've already mentioned the drugs that we have. I'll be predominantly talking about the smaller molecules. Vedolizumab, we all know it's an anti-integrin inhibitor, which basically blocks the alpha 4 beta 7 integrin, and that. So this was one of the first and post TNF failure drugs to be introduced into the market, and it was approved for UC in 2013 and CD in 2014. And recently in 2024, they have also published data where a subcute variety can be used. It's not only an IV, so and it's fairly good in terms of side effects. The interleukin blockers, P40 and P19 blockers. So if you look at this cartoon, you have IL-12 and you have IL-23. The IL-12 and 23 has a common subunit, P40. So this P40 is usually blocked by ustekinumab, but the IL-23 has a P19, which is more specific, and these Zumabs, Rizan, Gucel, Brazi, and Mirki, they block the P19. So they have actually lesser side effects because the effective blockage of P19. So this ustekinumab, actually, it was studied for both induction and for remission in CD, and they found that in patients who are actually anti-TNF naive had better response than patients with TNF experienced, and this effect was seen at maintenance also at 52 weeks. They compared ustekinumab with vedolizumab, and they've clearly found that ustekinumab was superior to Vido. So it's a better drug, but obviously all these have cost constraints. The next drug is risankizumab. Risankizumab is a P19 blocker, and both in the induction and remission phase, it's found to have a superior effect to placebo. The most frequent side effects reported with risankizumab is usually non-specific symptoms like headache and nasopharyngitis. Though in this, you can see that around 1.4% developed anti-drug antibodies. None of them had any neutralizing effect. So there was no effect of anti-drug antibodies on risankizumab. So it's the efficacy may be better than your TNFs. And this is another study which looked at superiority to among the both P40 and P19 blockers, and they found that risankizumab was superior in terms of endoscopic remission at week 48. Going on to smaller molecules. So what is the definition of smaller molecules? They have a low molecular weight. They are chemically synthesized. They do not have an immunogenic nature. They have shorter half-lives with faster onset of action. Orally administered, which is good, and it's relatively cheaper. Problems are that because it blocks many cytokines pathways, it may have more adverse effects and more drug-drug interactions. The first of which I'll be talking about is the JAK inhibitors. JAKs are a family of intracellular tyrosine kinases first discovered by Wilkes in 1989. So this is the picture of the JAK molecule, the receptor. So it's basically a cytokine receptor where the cytokine molecule comes and attaches to it. And this is a JAK. This basically JAK again phosphorylates the STAT proteins, and these go inside the nucleus, and the transcription of proteins occurs. So what are the JAKs that we have? We have the JAK receptors are JAK1, 2, 3, and tyrosine kinase 2. And we have some 7 transcription factors. JAKs have been commonly used in rheumatoid arthritis and psoriasis. So our data on JAKs actually is pretty good. So what are all the JAKs that, so we have most of the JAKs blockers are block JAK1 and 3 receptors. So tofacitinib actually is a pan-JAK inhibitor. So mostly blocks 1 and 3, whereas upadacitinib and filgotinib are JAK1. So they have actually lesser side effects compared to tofacitinib, which is a pan-JAK inhibitor. So tofacitinib, all the data shows that it is efficacious in UC, in both in terms of endoscopic healing and clinical response rates. When you look at the studies with all the 3 JAK inhibitors, that is filgotinib, tofacitinib, and upadacitinib, all those have both in the induction and in maintenance, all have efficacy compared with placebo. What about in acute colitis? Acute colitis is an emergency. So in acute colitis, usually we commonly use IV steroids, and if they fail IV steroids, our rescue treatment is either surgery with colectomy, or it's infliximab or something like cyclosporin. So in this study, they have looked at the retrospective study. They have looked at 40 biologically experienced acute colitis patients and matched with 113 controls, and they found that the colectomy rate was 8%. But in this patient, they have used a much higher dose of tofacitinib. They have used around 10 mg thrice daily. 10 mg thrice daily is not the commonly used dose. We usually use it at 10 mg BD for induction and 5 mg BD for maintenance. This is a study which was done in India by one of our alumni. So in that also they have found this is a single center RCT which looked at again in acute colitis patients. 10 mg TDS tofa was given and placebo was given 50, and all patients received the standard of care, which is IV hydrocortisone. And they also found that there was the response to therapy was higher in patients who used tofacitinib, and even the need for rescue therapy was also lower in patients who used tofacitinib along with your standard of care. So where does tofacitinib picture in the acute colitis scenario? It is not the first drug of choice. It is still steroids. And if steroids fail, then we go to Inflixi or cyclosporin. And that is still, tofacitinib is only the third option. Obviously, if everything fails, we call the surgeons. What about data on long-term use of TOFA? Actually, TOFA is actually, though all the studies scare us by saying that it can have thromboembolism, etc., but in the only adverse the incident rate was more than 2 in herpes zoster. The main thing they found was in RA studies, they say that in rheumatoid arthritis, most of the people are little older and they have more cardiovascular risk factors compared to people in IBD who have younger and with lesser cardiovascular risk factors. So that is why the major cardio events are less. Side effects of JAK inhibitors. Um, so most what do we monitor? We monitor your lipid profiles. They can also have cytopenia, liver problems, thromboembolic events, pulmonary embolism, and venous thromboembolism. So what are the contraindications? It's definitely contraindicated in active infection TB. It's contraindicated in pregnancy. It can cross the placenta, and severe heart failure malignancy. Elderly people is used with caution, and especially if they have any of their OCPs or if they have any vascular risk factors, use it with caution. So I've already talked. So what do we do before we start tofacitinib? We usually give them a recombinant vaccine, Shingrix vaccine. It's not available in CMC. We use it at 0 and 2 months. We usually vaccinate before or at the time of starting JAK inhibitors, and it's shown to have prevent herpes zoster infection 97%. What about people going for surgery? We generally stop tofacitinib 3 days pre-op, and we can restart it 2 weeks after. If it's an emergency, obviously you go ahead. Special population, like I already mentioned, elderly people we tend to avoid. Renal in ESRD, less than 30 creat clearance, we avoid. Hepat typically avoid in child C and use it with caution in mild or moderate hepatic impairment. What do we monitor? Like I mentioned, apart from your usual hemogram lipid profile, we have to keep monitoring them for if they're developing any venous thrombosis, also for latent TB before starting treatment. TOFA is available in CMC. It costs around 31 rupees per tablet, IMG tablet. So that works out to be around 3,780 per month for 10 mg BD tablets. That's the induction dose. Upadacitinib is beyond the reach of most of the patients and even doctors. 1,96,000 per month. Upadacitinib, it's approved for UC and for Crohn's disease. It's the only JAK inhibitor which is approved for both the diseases. And it's also teratogenic. Sphingosine receptor modulator is the next drug I'll be talking about. So what does it do? How does it act? So basically the sphingosine receptor in the lymph node, what it does is it blocks the egress of lymphocytes along the gradient of sphingosine receptors. So basically it internalizes, once the modulator attaches it to the sphingosine receptor, it internalizes the receptor, and that prevents the egress of lymph nodes to the sites of active inflammation. There are some 5 receptors, ozanimod, etrasimod, and ozanimod and etrasimod are the commonly used sphingosine receptor modulators. Ozanimod has also been approved for MS. The efficacy of ozanimod at 52 weeks, it clearly showed that it was better than placebo and there was durable remission. What are the problems with ozanimod? Because it has multiple areas, it has receptors in the brain, etc. It can, and the heart, it can cause hypertensive crisis, bradycardia, especially in patients with AV block. You should use it or with caution. Around 50% fall in lymphocyte count, and also macular edema can occur. So what specific things that we do before starting this drug? We do an ECG and also do an ophthalmic evaluation before starting ozanimod. Okay, so what is the safety pyramid of small molecules? So like we all know, steroids has a lot of side effects. So does azathioprine and your anti-TNFs. Then you have your anti-thiopurines, JAK inhibitors, and your recently approved drugs, the P19 blockers, are actually pretty safe. So to conclude, there are several new treatments already available, are in the pipeline. They are effective and safe. Future of management will be combining all these things. Personalized approach to you will be the key to success. Obviously, cost constraints are a big thing. So as soon as these biosimilars come for all these risankizumab and all these drugs, they